Thanks to everybody who came to FICIN today. It's a real pleasure to introduce Finbar Foley. He's one of the tribe. So I don't know how much introduction Finbar really needs, but it's always interesting to take a step back and look what people have done before actually they came to Yale. And Finbar is one of these people who has a ton of initials after his name. And I had forgotten about this, but he went to Yale as an undergrad and majored in political science. And then went off to CUNY, New York, City University of New York, where he got a master's in elementary and early childhood education. You can think of us still as kids here in the audience. And then he went to Hopkins to get an MPH. Then after he did those 2 degrees, he stayed at Hopkins to get his MD, stayed on at Hopkins to do his internship and medical residency, and actually was an instructor there before going off to Mayo Clinic to do his pulmonary and critical care fellowship. And then we were very lucky to recruit Finbar here to the section of pulmonary care and sleep at Yale, where he has been ever since, and he's assistant professor now. I point out that in the section, he won the Richard Mathey Award for Excellence in Medical Education. And he really, Finbar is recognized as a great educator. And I had forgotten that he has that extra degree in education. And so again, he's used to teaching us kids. Those of you who have heard me present people for pulmonary grand rounds know I like to look back and see what kind of the first thing they did was. And so Finbar, given that background, has sort of an interesting list of publications and presentations. And let's see. Right, so, no, where is it? Sorry, I saw this really interesting thing. Oh, here it is. His first presentation in St. Louis was on the association between maternal stress and development of child overweight status in a low-income population. And I think that probably reflects your public health interest maybe at the time, but also the interest in early childhood education. And so we've been very lucky to have Finbar here. He's been clinically incredibly active and a huge contributor. And I remember when Finbar came to interview for his faculty position that he had done all this interesting work at Mayo in quantification of normalcy as well as disease processes in the lung using computer techniques. And actually looking at the CV, there are publications and presentations on computer-aided lung informatics for evaluation of normal volunteers, IPF, the lung in IPF, and actually also emphysema. So it's great to see that you've continued that interest. I think this is a really important topic in the future, considering the incredibly increased use of CT scanning. So I'm looking forward to this talk on the future of lung nodule assessment, computer-aided detection and classification. Thanks for speaking.
Thank you very much for having me back again. The last time I talked a few years ago via Zoom in the pandemic, couldn't see the faces. At that time, I was talking about computer-aided diagnostics in diffuse parenchymal lung diseases. And so my research at Mayo was also involved in lung nodule assessment. And so that's some of the information that I wanted to present to you all today. If nothing to disclose, some of my colleagues are patent holders of some of the devices that I'll talk about, but I do not hold the patent and receive no royalties from anything that I talk about today. The objectives today, just to set the framework for what we're talking about, the current epidemiology of lung cancer. We'll then go on to the current strategies for evaluation of lung nodules, both detection and subsequent management. We'll then introduce some of the basics of machine learning to have an understanding of how we're applying artificial intelligence to this task. We'll then explore the development and use of computer-aided lung nodule detection tools, and then the use of radiomics and the risk stratification of lung nodules. And the 2 specific devices that I worked with were Canary and Broders at Mayo. And then finally, we'll take a step forward talking about opportunities for deep learning applied to this field, and in particular, Sybil, which was introduced to the world to great fanfare in 2023. So to again set the background for why this discussion is of vital importance, the map that we're taking a look at here represents the #1 cause of cancer mortality in countries throughout the world, men on top, women on the bottom. As you can see on the top, wide swaths of blue surround our globe. Those are not the blue oceans, but the blue of lung cancer mortality. Among men, certainly highly represented. On the map below, certainly North America and China, very high representation. And while breast cancer is the highest cause of mortality in other countries, you can bet that a significant number of them, lung cancer is the second most common cause of mortality. And so in 2020, lung cancer incidence was only exceeded by breast cancer by about 50,000. But when we take a look at the cancer deaths, we see that lung cancer jumps to the forefront in terms of mortality. It essentially doubles the number of deaths of the second most common cause worldwide of cancer-related mortality, colon and rectal cancer. This map is specific to lung cancer, men again on top, women on the bottom, age standardized lung cancer incidence rates, just to get a gestalt of, again, the burden of lung cancer incidence throughout the globe. Obviously, in the United States, the numbers are not good from what we learned before. The second most common cause incidence of cancer among men and women, and the #1 cause of cancer-related mortality in men and women. That comes to about 350 lung cancer deaths per day. If you imagine the people that we've taken care of who've passed of lung cancer, imagine having that experience throughout the United States 350 times on a daily basis. If we take those individuals who never smoked in 1 year, approximately 20,500 deaths due to lung cancer are in non-smokers, comprising about 20% of the cancer-related mortality. If in fact we took that as its own category, it would alone be the 8th leading cause of cancer-related deaths in the United States, non-smokers who developed cancer and died. Historically, unfortunately, lung cancer outcomes have been quite poor. They presented at a late stage of diagnosis, and treatments were relatively ineffective in achieving survival. However, survival has been improving over time. So if we take a look here at the trends in survival between 1975 and 2018, here primarily in the top part of the graph, the non-small cell lung cancer mortality curves appear to kind of take off around 2003. And I'll highlight a few things that occurred in the timeline that are of kind of significance in explaining this. So this star refers to the first EGFR inhibitor, gefitinib, approved by the FDA. A little bit later, this star will come up in the talk fair amount. The U.S. Preventive Services Task Force first made a recommendation for low-dose CT for lung cancer screening. And here we have the first cancer immunotherapy approved by the FDA for non-small cell lung cancer, nivolumab. And to refer again to the U.S. Preventive Services Task Force recommendation, it's the seminal 2011 NLST data that showed us the impact of lung cancer low-dose CT screening as compared with chest radiography, a 20% decrease in mortality in subjects who enrolled in lung cancer screening. And so it seems that we truly are potentially improving survival through earlier diagnosis. Taking a look at this graph here in the lung cancer incidence from 2004 to 2019, what we see in the graph is that here around 2015, the incidental cancers diagnosed at a local stage as opposed to regional or distant starts to kind of, the curve starts to overtake the regional diagnosis. And again, for the purposes of timing, the U.S. Preventive Services Task Force, a recommendation in 2013, precedes this change in recognizing cancer at a local level just a few years afterwards. And it's vitally important that we're diagnosing cancer earlier. Here in this data between 2012 and 2018, we see that if cancer is diagnosed at the local or regional stage, the survival is greatly enhanced over those cancers that are diagnosed at a more distant level. And so in summary, for this section, lung cancer carries a high prevalence and mortality in the US and worldwide. The incidence in non-smokers is increasing, so we have to consider that population, which will not be picked up in typical screening. Survival is improving, likely driven by better therapies and earlier diagnosis. And of course, chest imaging is a vital tool in this battle. However, it gets complicated. Nodules are identified in 1.6 million individuals annually in the United States. 30% of chest CTs contain a lung nodule. 50% of patients with a nodule have more than one nodule. And unfortunately, approximately 95% of all nodules on CT are benign. I don't mean unfortunately that I wish there's more cancer, but rather, unfortunately for us, we have to pursue all of these lung nodules with, in the end, only 5% of them being cancerous. Hence, it creates a dilemma for screening and targeting our populations and achieving, the best utility possible. For current nodule management strategies, given that we have these millions of nodules appearing, we have to have some framework for deciding what we're going to do when we find a nodule. And so I kind of put together this information for you all to highlight some of the big society guidelines. I'm going to focus mostly on Fleischner and LungRADS, which was most recently updated in 2022. Just FYI, there was a 2013 ACCP set of guidelines, hasn't been updated since 2013. One other kind of teaching point I'd like to make, we often, as pulmonologists can kind of consider, I'm going to quote Fleischner for everything. Really, Fleischner Society guidelines were developed for incidental lung nodules, whereas LungRADS was specifically designed following the NLST and Nelson data for screen-detected lung nodules. So, that's why we think about Fleischner if it's incidental. If it's encountered in the course of low-dose screening CTs, we're going to cite LungRADS for our decision on further follow-up. And as you can see, all of these guidelines follow a similar pattern. Some kind of mechanism of determining the size of the nodule, a mechanism for determining when a nodule is deemed to not require more intensive evaluation, either no longer follow-up or simply return to annual screening if it's low-dose CTs, and then criteria for further investigation. Now, I've highlighted here the criteria for further investigation, and I'll point out that several of them recommend the use of either clinical judgment or some kind of clinical stratification tool for assessing the relative risk of this nodule being malignant versus benign. BROC/PanCan score is used in 2 of the guidelines. ACCP used the Mayo model. I'll talk a little bit about that in a future slide. As an aside, growth assessment in Fleischner and LungRADS was 2 millimeters and 1.5 millimeters respectively. And that's not because there's some kind of biological nature that once it grows 2 millimeters, that's a warning sign. Data has suggested that the intra-reader reliability in assessing the size of a lung nodule, so ask the same radiologist a few weeks later to take a look at the same nodule, and they may alter their size assessment by approximately 1.6 millimeters. Inter-reader variability is on the order of 1.7 millimeters. So the reason we say 1.5 to 2 millimeters of growth is true growth is because anything less may be within the error rate of individual reading. So you always want to kind of consider when you hear, the nodule's grown by 1 millimeter, it's within the error bars of our ability to actually assess the change in size of nodules. So generally, our approach to lung nodules is going to be, we found a nodule. Is this obviously cancer? Is it obviously benign, or is it indeterminate? If it's indeterminate, well, we're going to have to somehow risk stratify and say, we're going to do something about it, or we're just going to watch it. And so how do we risk stratify? Well, we may use clinical judgment. We may use a prediction model. Ultimately, if the risk is high enough, we're going to intervene, send them to thoracic surgery. If we determine that the risk is pretty low, we discharge them, say no further follow-up, or return to annual screening. If, however, we arrive in a kind of gray zone 5 to 50%, we're not sure how risky this is, well, we need to further risk stratify. How might we further assess a nodule for risk of malignancy? Well, PET CT, maybe we'll do a transthoracic needle biopsy, try to get some tissue, or the decision to pursue interval imaging is a further way to risk stratify. We're going to say, I'm going to follow this closely in 3 months and see what happens. If nothing happens, I'm more reassured. If something happens, it's high risk. If it's still indeterminate, well, we have to keep risk stratifying. And so we continue going down that pathway until we arrive at a decision regarding intervention or discharge of the patient. So how do we kind of make our clinical predictions? Well, sometimes clinical gestalt is a way of doing it, but we do have 2 primary models that can help us. The Mayo Clinic model was arrived at in 1997. Specifically, I want to highlight it was derived from a population of incidental nodules found on chest X-ray. So when we're using this model, it may be a little bit more discriminative in populations of incidental as opposed to lung cancer screening nodules. This included smokers and non-smokers. So again, if we're picking up the incidental, don't know this patient's background population, maybe the Mayo model is going to be more helpful. In this population, 23% of the nodules were malignant. So clearly the baseline level of malignancy is higher than our average population. The predictors, I'm not going to go through them all there. They're there for your purview. But the area under the curve of this study was approximately 0.80. The Brock-Pancan model was developed in 2013. You'll also hear it referenced as the McWilliams model or the Tamamagi model. If you go on UpToDate, that's the model for lung cancer clinical risk prediction that you'll typically see. These were screen-detected nodules in the PanCan study. So by definition, they were entered into a screening program, hence they must have been smokers or prior smokers. 30 pack years was the requirement. Over 2,500 subjects were enrolled, 5.5% of the nodules were malignant. So this is typical of our screen low-dose CT populations. The predictors, again, have been provided for you to take a look at. The area under the curve was approximately 0.94, although that dropped if the nodules are less than 10 millimeters. If we use a 5% threshold, meaning any nodule less than 5% is determined to be benign, we're 71% sensitive, 95% specific. Unfortunately, the positive predictive value is pretty low, but the negative predictive value is great at 99.6%. If this is applied to an LST, only 5.5% of the nodules will be considered positive. So we're really trying to reduce the false positive rate. I highlighted here that between the two models, age, nodule size, upper lobe location, and spiculation were both independently held to be important predictors of malignancy. So we've got a great area under the curve, 0.94. What else do we need to ask about? Well, unfortunately, in real life practice, in 2017, applying these parameters to NLST, we had area under the curve of 0.84 and 0.82 respectively. If we applied it to incidental lung nodules greater than 8 millimeters, the Mayo model fared a little bit better than Brock. Remember, it was derived from an incidental population, but the discriminative ability starts to get poorer. And then Heidemann and Maldonado this past year applied it to individuals that were referred for navigational bronchoscopy, clearly a high malignancy prevalence population, and the models start to really fall apart in this area. And so limitations of our models are inherent based off of the prevalence of the population, comparing it to the studied population versus trying to translate that data to populations that it can't be generalized to, and a tendency to overestimate the risk inherent in the populations. So what's the problem with poor discrimination? So in the NLST trial, the number needed to screen to prevent one lung cancer death was 323. So the more false positives we're picking up, the more people are being exposed to the harms of screening without the benefits of screening being obtained. Pinsky in 2014 kind of created this visual image. If we take 1,000 patients entered into NLST, what ultimately happened to them? The black stars are all negative people, people who went through, nothing happened, and that was appropriately so. 27% of the individuals had at least one false positive. Those false positives generally resulted in further imaging, but in fact, in 17 of those cases, an invasive procedure was performed on the basis of a false positive result. There's the theory of overdiagnosed cancers, which I won't go into in great detail. The estimation was about 11%, but numbers range from 10 to 60% overdiagnosis. And the idea behind this is if a cancer is sufficiently indolent, it may exist throughout the life of a patient without ever making itself symptomatically known. That essentially the patient would live and die with a lung cancer never having been diagnosed, but for the fact that they were enrolled in a screening trial. And so if we're intervening on patients for whom overdiagnosis is their issue, they're ultimately going through attempted curative procedures that in their lifespan probably wouldn't have been needed, similar to individuals who have a very indolent prostate cancer who may die before their prostate cancer ever turns into anything that they needed to worry about. On the good side, screen-detected cancers and 3 lung cancer deaths prevented out of 1,000 people screened. So clearly there's room to try to shift things towards more benefit and less of the false negatives, false positives, et cetera. So how can machine learning help? Well, one method is by computer-aided detection, hopefully helping us to more accurately detect nodules and avoid the problems of false negatives. And then I'm also going to talk about radiomics, which I'll define a little bit later, but that's essentially going to be using computers to help us to solve the false positive issue. When we come up with an indeterminate nodule, how do we figure out what the heck it is? But first, what is machine learning? So, we've heard tons about it in the past couple of years, ChatGPT, Bard, all of these AI systems, and people throw out AI, machine learning, deep learning. Are they all the same? Are they different? The terminology gets a little bit confusing. So I'm going to break that down a little bit on the next slide. Artificial intelligence refers to overall having computers simulate human intelligence. Machine learning is a subset, and then deep learning is a further subset of machine learning. And so breaking it down, simulating human intelligence, any computer that does this is artificial intelligence. Machine learning specifically uses algorithms, models, statistics to interpret data, identify patterns, and ultimately make predictions. Now, human intervention is required. We have to tell the machine what are the things that we want it to analyze, how is it going to analyze those things, what models are going to be used, and what output is important. And if we don't get the output we want, we feed it back into the model, we train it further. So it requires a lot of human intervention. On the plus side, less data is required because we're telling the computer what it needs to know. Deep learning is simulating the human brain through neural networks. It requires significant amounts of data, and that's one of the inherent limitations in applying to lung cancer. But it does not require explicit human inputs to train, and it also can improve over time. So examples of non-machine learning AI. So computers that seem to act like people, but there's no thinking going on. So Clippy from Microsoft, helpfully suggesting how to write a letter, tries to communicate in a human form, but really it's an algorithm of if this, then this, if this, then this, if this, then this. It's tax season, just a reminder, this may be the best thing that you take from this talk today. I use TurboTax. It communicates with you in a chatty method. Hey, we're working together today. We know taxes stink. We're in this with you. There's no human heart behind it. Again, it's all an algorithm. If you've invested in Bitcoin, you need to declare your income from that. A chess computer, at least a simple chess computer, is programmed with many different endpoints. It's programmed with how to do moves and some means of determining is one move better than another. But the more times you play it, you may get better. You may ultimately defeat your little chess computer. Your chess computer is never going to get better than you. It's going to do the same thing every time. It's simulating learning chess or knowing chess, but it's not learning. Whereas machine learning is taking it a step further. It learns from inputs. And so when you get your Netflix recommendation, it's learned from your patterns. It knows kind of certain factors of the movies you're watching and how they pertain to things that you might be interested in and makes recommendations. In case you didn't know, it's even kind of deeper than just making the recommendations. Literally the way that they align the rows and the columns is designed to try to attract your attention more. So that's the extent to which they're thinking about you and trying to program you. Facial recognition, same thing, learning over time, feeding in the factors in order to better enhance facial recognition. Email spam filters are trainable. It eventually learns over time what do you consider to be garbage versus what do you consider to be important. So the main types of machine learning is, again, the algorithms that are used to help to train the computers are regression, classification, and clustering. Regression and classification are supervised, meaning a human is labeling it, correcting, training, and going through the validation sets. In regression, we're establishing the correlation between dependent and independent variables and its continuous data, as opposed to classification is dividing it into discrete data. Kind of an interesting form of machine learning and one that was used in the Mayo programs that I'm going to talk about is unsupervised. The machine is figuring it out. So clustering, you present the algorithm with data and the data, and the machine utilizing the algorithms with which it has been programmed will work to cluster the data into the things that are most similar and provide that information back to you. Whether that clustering has any value is up to ultimately us as humans to determine, but the machine will say, there seems to be something that links these things and differentiates from these other things. But when you apply it indiscriminately to lung cancer, it may say, oh, these emphysema findings are really interesting, but it may also say these calcified things are very interesting. Do we care about the clustering? That's up to us to determine. So I did want to highlight the difference between machine learning and deep learning. Dr. Clark isn't here today, so I figured he wouldn't mind being brought back into this in spirit. He's on vacation. And so let's say we want to train a machine learning algorithm for facial recognition. So we can't just feed the computer a picture of Brian. We have to tell the computer what are the features inherent in a photo that needs to be attended to. It can't look at the pixels and know what we're thinking. We have to say, oh, we want you to focus on these aspects of a picture in digitized numerical form. So once we've told the computer what to attend to, we further have to say, okay, computer, what are the aspects of this data that we want you to attend to? What do we believe as humans is important in facial recognition? So roundness, eye distance, nose width, cheekbone, et cetera. And then once we've told the computer the data to pay attention to, how to interpret that data, and we've programmed it with a certain algorithm in order to process it, we can train it over time to perform appropriate recognition and differentiate Brian from the sea of faces that might be in the crowd. A neural network operates differently. So once again, we present the neural network with Brian and a whole series of other faces. It doesn't require us to adjust the input. It can take the pixels as they are, learn what's important in the patterns, feed it through a complex set of nodes that we essentially think of as equivalent to human neurons. And it goes through multiple layers of interpretation. When we refer to deep learning, the depth of learning is the degrees of hidden layers. 3 or more is going to be considered a deep learning. And ultimately, over time, exposure to many, many faces, the machine determines its own way of figuring out from pixels how to recognize faces, and more specifically, how to recognize Brian's face from out of a crowd. But when we want to go back and say, computer, how did you figure it out? The computer's going to answer, I don't know, it's just Brian. I can't tell you how I figured it out. And that's one of the problems in deep learning is it's a black box. We put in data, it gives us a prediction, but we don't know what it's doing. And that leads to some discomfort with applying it clinically. So how is this helping us with diagnostic errors in lung nodule radiology? So the primary diagnostic error is going to be false negatives. There are kind of thought to be 3 reasons for diagnostic error of this type: scanning, recognition, and decision-making. So scanning is essentially, if you fail to look at the lesion, you're going to miss the lesion. So if you're reviewing your chest x-ray and you fail to look at the humerus, you're not going to pick up the humeral fracture. Recognition error is you attended to the lesion, but you scanned that area, but you failed to recognize a lesion was there. So you went through your protocol, you did successfully look at the humeral area, but you didn't recognize that there was a fracture present. And then decision-making error is you did attend to the correct area, you did recognize that a lesion was there, but you falsely assessed the lesion as something other than what it was. Oh, I see that line there. I don't think it's a fracture. I'm not going to call it. Contributors to increasing error, particularly within the world of lung nodules, radiologist workload is increasing. As we develop low-dose CT programs, those millions of nodules are going to continue to extend. There's increasing data per CT. So the more slices that we do, the more slices a radiologist has to go through. And in particular in low-dose CT, given artifact, there may be more artifacts picked up that have to be further discerned from true positive findings. And all people suffer from fatigue and diminished alertness. And so what is the cost of false negatives? So McCready in 2008 said, overall, the most common type of radiologic error is false negative on a CT scan. In NLST, 6.2% of identified cancer cases had a negative screening result. So at the end of the study, these were patients ultimately found to have cancer who were never in any of their screening CTs diagnosed with a cancer. So that's our false negative rate in NLST. Lee in 2002, in another study of 83, noted that 32 out of 83 cancers were overlooked on low-dose CT. Swenson in 2002 was looking at low-dose screening CTs over time, and the baseline scan found 782 nodules. At 1 year scan, what they did is they looked at all the nodules that picked up in 1 year, and whenever there was a new nodule, they went back and said, oh, did this nodule pre-exist on the CT a year ago? 375 more nodules were found when referencing subsequent CTs and looking back at what was missed. And so what is the cost of this? Delayed diagnosis and stage shift, I already went through. If it's a year or 2 before a nodule that was there is recognized, we're stage shifting. Giarda noted that in NLST, all interval cancers, so CTs that weren't at baseline, but at stage 2 and stage 3, had an 84% mortality rate, whereas all screen detected cancers had a 35% mortality rate. Now, it's possible that a cancer that only arrived at screen 2 or screen 3 was a more aggressive one, but it's also possible that we were missing things at earlier stages. And it provides false reassurance. So your patient comes in, you do a low-dose CT, you're told there's nothing there. Oh, great. Maybe I'm going to put off coming back from my low-dose CT. Maybe I don't need to quit smoking because there's nothing there in my CT. Those are some of the other dangers that we might not think about false reassurance that you had a negative CT scan. So one way of solving this issue is double reading. This study by Warmans, I highlighted here the two groupings. The more readers that were applied to a given CT scan, the increased sensitivity. However, to implement such a plan, you need more time, you need more radiologists, you need more money, and that's going to be difficult to pan out. And so this is a realm ripe for computer assistance. And so computer-aided detection is potentially a way to do double reading in radiology, reducing the false negative rate. So how does this go about? So first we acquire the data, person goes into the CT scanner. The image is then pre-processed, refined for our computer-aided detection algorithm to better be able to process and identify lung nodules. The lungs then have to be segmented. So we have to get the computer to hone in on only the lungs and not all of the other data that's external to the lungs. Following the lung segmentation, now proceeds to nodule identification. So some type of algorithm that the computer is programmed with now identifies all the spots that are potential nodules. Obviously, a lot of things are going to be picked up that are potential false negatives. And so the computer is then programmed with a mechanism of winnowing out the false positive nodules and honing it down to the things that are most likely to be true positive nodules. And that is ultimately fed forward to the interpreting radiologist. And I want to highlight here, when I talk about true positive nodules, I'm not saying true positive cancerous nodules, just simply spots that are really spots and not things that look like nodules. So computer-aided detection was found to have a time savings. It can detect, it can also calculate the measurements for the radiologist. So you don't have to throw your calipers on and take care of it. The radiologist can focus more on general image interpretation. In one study dedicated to lung nodule assessment, there was a 40% reduction in reading time when using CAD modalities. It improves radiologist repeatability. So the kappa of agreement for positivity of screening and follow-up recommendations went from the 0.5 range to the 0.6 range when using computer-aided detection. And furthermore, in this study, we can see that radiologist sensitivity to nodules is increased. I just highlighted reader 1 here, who had a 46% sensitivity when not using computer-aided detection. That went up to 66% when using computer-aided detection modalities. And so we have increased sensitivity, but of course that comes at the risk of increasing false positive nodule rate. On average, using computer-aided detection, 1.44 additional true nodules per case were identified, but at the cost of an increased false positive rate going from 0.07 to 0.15. It seems like a small number, but when stretched across millions of CTs, that's going to be many more false positives. Before I go to the next session, I just want to show another way that computer-aided nodule detection can occur. So as opposed to just a CT scan identifying a nodule, artificial intelligence can help us to better look at CT images or X-ray images and pick up on the lesion. So here, machine learning has been trained in order to remove ribs from X-rays. And so the nodule that's in the right upper lobe really jumps out at us. Similarly here, I mean, you wouldn't miss that nodule, in most circumstances, but this does illustrate the fact that cutting out the vasculature really helps the nodules to stand out. Of course, there's always the chance that the algorithm cuts out something important, and there's still a little bit of artifact noise present. And so it's not perfect, but it really kind of helps radiologist assessment. So in summary, computer-aided detection increases sensitivity, decreases radiologist cognitive load. It increases repeatability and agreement, and it may allow automated measurement of nodules. And this could conceivably be applied to incidental lung cancers, incidental lung nodules rather. So CTs that are being looked at for other purposes, traumas, PE, et cetera, a computer-aided detection system could be running in the background saying, oh, hey, there's a nodule here, you should be aware of it. The things that often get missed when a radiologist suffers from satisfaction of search. They were told to look for a PE, they found the PE, oh, there's a nodule in the background, but I wasn't looking for that, and I missed it. So our issue now is false positives. That's things that aren't really nodules, and I talked about that before, but then there's also the nodules that aren't actually cancer. And so this next part of the talk is going to be radiomics, techniques to minimize the false positive rate when assessing lung nodules. So how do we do it right now? Well, currently we describe nodules according to semantic characteristics. So we use words to describe what we see. Is the nodule round? Is it spiculated? Is it solid, subsolid, or ground glass? What's the texture? And in fact, the Brock model, looking at UpToDate, uses a number of these semantic criteria in defining lung nodules. However, the things that we humans can look at and use our semantics to describe are only a small fraction of what's present within the radiographic data. And so that's the field of radiomics. So radiomics is taking quantifiable features that could be extracted from the medical imaging data, essentially radiographic biomarkers. Now, in some cases, these radiographic biomarkers can be semantic, so we can program machines to tell us the size of nodules, just as we can do it ourselves. But there are also elements within the data that we may not perceive, certainly kind of not on a conscious level. So we'll talk about the Hounsfield unit density distribution, histograms, kurtosis, skew. And some of those may be things that we kind of perceive as, that nodule looks a little bit fuzzy. That nodule looks coarse. Something strikes me about that nodule as I think it's a higher risk of malignancy. We can't really put that in a model, gut feeling, question mark, is this cancer? But there may be aspects of our intuitive gut thinking that are specifically within the radiographic data and can be quantified. So we then take all of this radiological data and we data mine. We apply mathematical analysis to the features to try to derive predictive models. So this is a step beyond the standard radiologist evaluation, getting into the hard data and seeing, is there anything there that tells us about cancer? This is particularly useful for lung nodules because lung nodules are, compared to other things, really relatively easy to segment from the remainder of the lung parenchyma. And because nodules probably consist of genomic heterogeneity, that translates into some kind of radiographic heterogeneity. So when you see differences within the nodule, that may translate into biological differences within the nodule. And then finally, the presence of numerous data sets allows this to be applied to machine learning and deep learning modalities. So the first program I'm going to talk about is CANARY, the Computer-Aided Nodule Assessment and Risk Yield. We kind of described this as a radiographic biopsy. So this was designed for the non-invasive risk stratification of lung nodules within the adenocarcinoma spectrum. So this is derived from patients in the Mayo Clinic Epidemiology and Genetics of Lung Cancer study, and then subsequently validated the Mayo Clinic Thoracic Surgery Registry. We took surgically resected adenocarcinoma spectrum nodules. They were defined as adenocarcinoma in situ, minimally invasive adenocarcinoma, and invasive adenocarcinoma, and the percent lipidic growth was defined. And then the nodules were extracted according to a semi-automated modality. We had to pick out the nodules, but then there was a seed growing method in order to encompass the nodules. So I'll be talking a little bit of radiology terminology, pixels and voxels. So if we look at a two-dimensional screen, we divide it into a matrix. Each single point of that matrix is a pixel. However, in radiology, when we're looking at CT slices, each slice has volume. It might be a 5 millimeter slice, it might be a 0.625 millimeter slice. But either way, when we're looking at a piece of data on a CT slice, we have to consider that not only is it two-dimensional data, but there's a third dimension, the slice thickness. And so a volumated pixel is a voxel. So when creating the CANARY program, what was done is our radiologists picked 774 regions of interest that were 9 by 9 voxels that characterize this nodule throughout the adenocarcinoma spectrum. So 774 of these randomly distributed ROIs were fed into the computer. And then we proceeded with one of these unsupervised clustering algorithms. The one we used was affinity propagation. And so the system determined what is the natural clustering groups of these 774 regions of interest. And ultimately, it dropped down to 9 clusters that were ultimately defined by a certain color. And we then went back and said the centermost region of interest in that color was going to be defined as the exemplar. So kind of the Platonic ideal of violet is going to be this type of ROI. And then once we define all of our exemplars, we kind of now apply that in the future to any other nodule that we see. So again, we went through, clustered, created 9 groupings, and defined what is the definition of each of these groupings. And so this is how the CANARY system works when applied to a CT scan. So we identify the nodule segmented. the machine goes through every region of interest in the nodule and paints it with the color of the exemplar that most fits that region of interest. And eventually, you've painted the whole nodule any of a set of the 9 colors. We then created this glyph, this circle. The surface area of the circle reflects the volume of the nodule, and the proportion involved with the circle indicates the proportion involvement with that exemplar in the lung nodule. We further then analyzed those clusters and found that several of the clusters seemed to group together. And as we looked further at the data, it became clear that the clusters here, VIRO, we termed it the VIRO clusters, seem to correlate with invasive adenocarcinomas, whereas the BCG group of clusters really seemed to stratify with the less malignant, less invasive adenocarcinoma in situs. And so we decided to kind of pursue that information further. This slide shows various canary nodules painted with varying degrees of the VIRO exemplar set. And we had the percent lipidic growth compared with the percent VIRO assessment by canary exemplars. And this was the validation and subsequent training set. And we can see the Spearman R for both validation and training was actually quite good at 0.87 and 0.89. And so we felt like what we ended up having here was a mechanism using a CT scan to image a nodule and tell us within the data of that nodule what was the histology, what was the percent invasion. And so the hope is that without actually needing to biopsy a lung adenocarcinoma, we could predict how invasive is this? And that might help with the overdiagnosis question. If we could, say, we don't want to biopsy this nodule, really looks like a lung adenocarcinoma. Can we apply a non-invasive biopsy to this, determine that it's adenocarcinoma in situ, really indolent growth, and then consider maybe a watchful waiting approach for this patient? So, the thought process here is that histology correlates with radiographic findings. This was further applied to all eligible lung adenocarcinomas in NLST. So again, we went through the canary segmentation, created a glyph for every lung adenocarcinoma in NLST. We then stratified that into the nodules that fit the VIRO pattern, the BCG pattern, and all of those that were in the middle group. And the Kaplan-Meier curve really shows that we're differentiating on the basis of survival. So this is the good lung nodules, these are the intermediate, and these are the poor, the VIRO. And so clearly with a P less than 0.01 for all of these differentiators, we successfully created a tool that's able to radiographically stratify mortality within the lung adenocarcinoma spectrum. We also were able to establish there's a connection with EGFR status. Again, testing our hypothesis that what we're identifying radiographically correlates with something that's real in terms of biology and genetics. And so a logistic regression and stepwise variable selection for EGFR status was performed. And we found that the yellow and green groups correlated highly with EGFR status. If we created a model with just the yellow and green exemplars, our area under the curve was 0.77. If we added in smoking status, our model's discrimination went to 0.85. And if we added in the presence of fibrosis within the tumor-free surround, our model went to 0.87. And so, really interesting here that you can get potentially a CT scan that can tell you the EGFR status. And so a couple of weeks ago, we were the beneficiaries of an excellent talk on liquid biopsy and finding these markers in the blood. Isn't it fantastic if we can find this information radiographically? So the take-home points of Canary, it's a means of non-invasive risk stratification of nodules in the lung adeno spectrum. Our assessment was predictive of survival, correlates with histology and EGFR. But it was not applied to indeterminate pulmonary nodules. And what I want to specify here is it's not a benign malignant differentiator. We already knew these were lung adenos. We were simply risk stratifying them on the basis of CT scans. So if we apply it indiscriminately to lung nodules, kind of unclear what would happen. So the lesson here, imaging carries histology and genetic data that is not perceptible to us normally. And we have opportunities to limit overdiagnosis. And so the next tool, Broders, was an attempt to go to that next step of finding a radiomics classifier that could differentiate cancerous versus benign. So we took 649 low-dose CT lung cancers and found that 408 were eligible for analysis. We took a stratified sample of 318 benign nodules for comparison. I'm not going to go through all the radiomics classifiers, but I wanted to highlight down here that these parts of the model were based off of the Canary tool that I showed you before. So we're using that kind of radiographic genetic histologic analysis and applying it now forward to try to determine benign versus malignant status. We had to create a continuous variable based off of those glyphs. And so here's where all of the malignant nodules in this NLST group versus the benign nodules in our comparison group were stratified according to the BCG VIRO groups. And we created this continuous plot, which we called the SILA index. So it's again using our radiographic histologic biopsy and now trying to apply that in a larger radiomics model to see if it could help us with discrimination of models. We use lasso regression to arrive at 8 selected features. I'm not going to go through all the features, but just point out that the features trended towards location, shape, texture, and surface characteristics. The AOC that was achieved in this training set was 0.939, with an optimal sensitivity of 90% and specificity of 85%. So this was further validated by applying Broders to incidental lung nodules at Vanderbilt. So this is one of the kind of golden opportunities, incidental lung nodules. So low cancer prevalence, arguably, and we don't know that necessarily a smoking history. We also compared to the Brock model, the current standard for assessing lung nodules. Across the full NLSD cohort, we can see that the Broders model had greater discrimination in the full cohort, and also when looking at low risk and intermediate risk. It's not surprising since Broders was derived from NLST data and Brock was derived from PanCan. We already knew that Brock started to fall apart a little bit when applied to NLST. And so a greater test was comparing with the Vanderbilt data. And once again, we see that in all areas, although the difference fell apart a little bit, the Broders radiomics classifier exceeded the Brock classification. So the take-home point here is, in the NLST cohort, we achieved 88.7% sensitivity, 86% specificity. In the Vanderbilt cohort, 92% and 62% respectively. The positive predictive value was 74%, negative predictive value of 87%. The benefit here was the model was trained on screen lung nodules, yet we were able to extend the predictive ability to lung nodules that are incidental. It performed better than Brock, which is currently our most common clinical prediction model. And we're able to dichotomize Brock further. So Brock tells you low, intermediate, and high. You have this large intermediate group of the 5 to 65% risk. This further splits those apart, bringing more people into the true test negative versus test positive population, minimizing the false positive rate. And so we found that radiomics-derived risk assessment discriminates lung nodules better than solely radiologist-derived semantic characteristics. And I'd like to remind you that this radiomics model did not at all take into account smoking history, family history, presence of emphysema, et cetera, all of those things that we put in the Brock nodule. And so if we apply an enhanced radiomics module and further add in some of that other data that we collect with respect to historical risk factors, our AUC would potentially grow even greater. This slide is just to tell you, if not told you, the whole story. So I highlighted a radiomics tool and kind of non-invasive histologic tool from Mayo Clinic. But in the literature, there are literally dozens of different computer-aided diagnostic tools and different radiomics classifiers. The problem with all of them is lack of appropriate external validation, lack of appropriate generalizability. The techniques are proprietary and thus not extendable for other individuals to validate. So the reason that hasn't hit prime time is, despite having dozens of different studies all saying that they can discriminate better than our current predictive models, nothing's risen to the fore as the gold standard. So in the last section, I'd like to talk about deep learning. So this is kind of like the exciting, sexier area moving forward. The chief type of deep learning classifier used is the convolutional neural network. And so that's a form of neural network which is found to be superior in kind of visual analog tasks. So if you're trying to do deep learning for face recognition, or in this case, radiologic image interpretation, this is the type of deep learning neural network you want. It can automate nodule recognition and segmentation, then proceed to analysis. So we don't have to pre-tell it, here's the nodule, here's the things we want you to pay attention to, here's what's important. We simply feed it the data and say, this is what we want to arrive at as your predictive ability, and then feed it through the cycle of the neural network multiple times. We then use data augmentation to provide more training. And so the limitation here is you need lots and lots of data, more than simply an NLST data set or a Mayo Clinic or a Yale registry. Thousands upon thousands of CTs are necessary. So one way of overcoming this is flipping the images. So here I showed you the letter F flipped across an axis, but also rotated 90 degrees. So the letter F can be seen in 8 different fashions, depending on how you flip the image. And to us, it's just, oh, you just took the letter F and flipped it around. But to a computer training module, these are all different tasks to learn from and develop your model from. So if you take the same CT and give it situs and versus, or kind of play around with the data, the machine kind of sees this as a new task to learn from, and you can augment your data in this fashion. Another cool way of doing it is called a general adversarial network. And what we're doing here is we train another neural network to learn how to make CTs. So the neural network is fed with many CTs with lung nodules, learns how to create a CT with lung nodules, creates an entire data set, and then the neural network that we want to train to differentiate benign versus malignant will use all of this data from the general adversarial network to train itself. There have been various AI competitions, and the poster that I put up here is from the 2017 Kaggle Data Science Bowl. There's an opportunity to win up to $1 million in prizes. And the 2017 Data Science Bowl was specifically dedicated to machine learning for lung nodule assessment. It was the 3rd one they had, and they decided this is a problem we want to try to solve. We're going to invite thousands of competitors from around the world to try to come up with their best models and win a prize. So what are the limitations here? They unfortunately poorly generalized to different cohorts. There's variation in data. I'm going to move through quickly because I want to get to Sybil. There's a hypothesis. Currently, we've only been looking at the lung nodule and saying, is this benign or malignant? But there's a whole lung to look at. And hypothetically, there's much more data within the whole CT to tell us, is this person at risk of cancer? And so Sybil was trained on LST data sets. Radiologists annotated data for the low-dose CTs taken a year before the cancer diagnosis. And this was validated at MGH and an institution in Taiwan. And what we can see here, this is the NLST data. Going from 1 year to 6-year prediction, we had an area under the curve ranging from 0.92 to 0.75. But what we're seeing is using whole lung analysis, not just focusing on a nodule. We're able to come up with a deep learning algorithm that was able, with some degree of fidelity, to predict the presence of a lung cancer developing in this patient before the cancer was actually there. And this was also validated in MGH and in Taiwan. I'll give us certain examples. They highlighted in the paper examples of nodules that were detected, that were negative per lung-RADS criteria, but that Sybil picked up as a true positive. So here's kind of the exciting example. This was a screening CT in which there was no nodule identified. And 2 years later, with an interval CT that showed nothing and then a subsequent 2-centimeter lesion, Sybil fired on this initial CT and said, this person is at high risk of developing lung cancer. And 2 years later, there it was. This CT was a false negative because this nodule was juxtapleural and radiology didn't pick it up. Sybil fired on this and said, this is high risk of lung cancer, and sure enough, it developed. Here was a screen negative lung nodule because it was too small. It just kind of fell to the level at which we say return to normal screening. But 2 years later, the nodule was established to be cancerous. And unfortunately, the image is kind of poor here, but we see a cystic space here, which really we have trouble with machine learning and lung-RADS determining the significance of cystic lesions, but sure enough, identified ultimately to be a lung cancer. Another exciting part here. So they took a look at Sybil and looked at the non-visible future cancer. So CTs where there is no visible nodule, and said, okay, Sybil, can you tell us which side the cancer is going to be on? The hypothesis that was being tested here is Sybil simply saying a given individual has a high risk of cancer, or is it possibly seeing something within the context of the lung specifically that's predicting risk? And so when Sybil fired and said this was a high risk of developing cancer, it predicted with an AUC of 0.86 what the laterality was. So it's not simply taking a look at the lungs and saying, overall, I think this person has a high chance of having cancer. It's picking up something in the data, in the CT of the lung before the cancer actually emerges to say, this right side looks bad. I think it's going to develop a lung cancer. And Sybil actually correlated with social aspects of our patients that were somehow seen in the CT scan. So Sybil was accurately able to assess so what happened here is they took the average level of the data at baseline, and then they took a look at how well Sybil was able to predict based off the low-dose CT. And if it was more accurately able to predict the presence of these factors according to baseline, that was telling us that Sybil was seeing things in the data beyond simply guessing the baseline prevalence of these issues. And so it was able to predict age, gender, sex, height, is this patient a smoker, and what was the duration of smoking? Certain of these things are kind of obvious. If there's no breast tissue on a CT scan, we can probably guess what the sex is going to be. But it's interesting that Sybil was able to sense, is this patient a smoker and how long were they smoking for? So again, it's arriving at biological data that's not simply present in our usual CT analyses. So the lessons here, whole lung imaging data, not just focusing on the nodule, but radiomics applied to the entire gestalt of the lung provides input into cancer risk. And some of this may not be visible to human readers. Applying such a tool during low-dose CT screening may help us identify patients in need of sooner interval follow-up. You get a CT that otherwise be read as negative, and you say, Sybil says you're at high risk. I'm going to follow you Q 6 months now because we have a suspicion something's going to pop up. It also may reduce the frequency of false positives that had better discrimination than lung rads. And therefore, we can say, Sybil says you're pretty low risk. I see a nodule here, but I'm going to wait 2 years to rescreen you because I have pretty good data to suggest this is not going to turn into a lung cancer. What are the limitations? It's CTs from the early 2000s. So there's been changes in our reconstructive algorithms since then that may not make it applicable to current CTs. There were 92% white patients in the LST cohort. And if you noted, race was not discriminated. One hypothesis is race has no role in the prediction of lung cancer, but we have a suspicion that certainly if we take race as a measure of various risk factors for lung cancer in a person's lifespan, we would think that race should stratify lung cancer risk. I worry that the reason it didn't discriminate race is because there's not enough of other races within the training data. The smoking status wasn't known in the CGMH patients, and ultimately, there's no documented survival benefit from this tool, so who's going to adopt it beyond what we already have? These are the overall barriers to adoption of these tools, but since we're kind of running out of time, I'm just going to go to my summary slide and open up for any questions. Thank you.
Can you repeat the question after
Yes.
it gets asked? Okay, don't repeat the question. So it always seems to me that these are great. They're kind of like giant, Sybil's like a giant biomarker, right? You use the whole lung to predict a lung cancer. Is there a way to incorporate the past information, the prior CT scan, which obviously we do in practice, but none of these models seem to incorporate?
So there are neural network models that have done that. I kind of described the two I was involved in, and Sybil is an exciting one. But there have been ones that have tried to use, to leverage prior data into creating risk prediction. So that exists. Again, it's part of the cohort of dozens of such models that haven't hit prime time, but that's definitely being done and continues to be done.
So Finbar, thank you. The term radiology or radiologist assisted,
Mhm.
I guess it implies that there's some sort of synergy between the radiologist and the machine.
Mhm.
So in other words, the radiologist could see things the machine didn't see. Is that the right way to interpret it? As opposed to saying, I mean, I want to keep these people in our lives. So how do you think about that?
So when I pointed to the CAD, see if I can get back to it quickly. When I went to
Computer-aided,
this chart.
computer-aided.
What I didn't point out here, kind of skip through it, the computer-aided diagnosis had at the outset a higher sensitivity than any radiologist did. But very few radiologists ultimately agreed with the same sensitivity. And so the CAD tool would say, here, there are 58 nodules. The radiologist would then review what the CAD tool told them and say, in some of these cases, I don't think this is a lung nodule. I think you got this wrong. And so because these things don't have perfect discrimination, it still requires a radiologist to make the final judgment call and say, oh, okay, you showed me some things I missed. I agree, that's a nodule. You show me some other things that I don't think are a nodule, I'm going to discard them. And there's also been literature in what's the right way to do this. So do you just use CAD without a radiologist? What happens? I don't think we're anywhere near doing that yet. But there's been literature in, do we have the computer-aided diagnostic go first and feed that information to the radiologist who reads with the luxury of knowing what the CAD has told them, versus the other way around, is the radiologist do their own read and then subsequently is told, here's what the CAD found. And by and large, it was found that the radiologist first, CAD later, was a more effective model, with the thought that, I brought up the term satisfaction of search before. If a radiologist is provided with the menu of here's all the nodules, there's a little bit of incentive lost to go peek through for every other nodule that may have been missed. Whereas the radiologist starts off the task looking for all the lung nodules and then is told subsequently, here are some you may have missed. Ultimately, that resulted in a better sensitivity specificity for lung nodule detection. But it is clearly they're arm in arm, not one is substituted for the other.
Yeah, I also wonder whether they're teaching each other, right? So if the radiologist sees something the computer pointed out, maybe the radiologist develops some mode of detecting something they wouldn't have seen before. And similarly, if the radiologist sees something, maybe the radiologist can teach the computer.
That backwards would only occur during the training of a neural network. In all likelihood, once it's put out for consumption to the masses, there won't be that training element. It'll be, here's the product, it's immutable, it'll always do the same thing. So in the process of training it, yes, that feedback can potentially be important. And yes, it's exciting to think that we as humans can maybe learn from what the computer is picking up. And, for example, in Sybil, can we back analyze and figure out what were the things it was picking up on? What can the computer teach us? So I certainly see the information going in that direction.
Hi, can you hear me okay?
Yes.
Okay. So thanks, Finbar, great talk and very comprehensive. One thing that I really don't see mentioned a lot with the AI technologies with radiomics and, for example, with the computer-aided detection, you talked about lung segmentation is often a primary step. I do that on mouse lungs, and sometimes I can take an hour or two per lung. It's a very technical and can have a very high computational expense. And I never see that mentioned in terms of what was actually like the computational efficiency of actually just showing it to a radiologist and reading versus letting these algorithms run. Because on a study, this could be a small scale and somewhat manageable. But if you have every CAT scan now in a hospital system running, without measuring that, I'm wondering if we even have the computational ability to do that. Have you run across that at all in any of the literature?
So the literature frequently reports, certainly within the computer-aided detection part of things, what the overall time taken to analyze a CT is, and across the board, the overall time appears to be decreased when using CAD modalities. So that's kind of built into that literature, the overall time, because part of what we're trying to say is by using these tools, you're more accurate and you're more efficient. That's the only way to get an institution to buy these things. When we're talking about whole lung analysis for lung nodules, the radiomic analysis, with use of the Canary system, the processing time was 3 to 5 minutes before it would feed information. I can't speak to what other systems would have, but I think it's going to be one of the barriers to wide adoption. So when I went into that chart that I had towards the end, the circle with the other things, what are the barriers to uptake? One of these was the physical structure of bringing these to prime time. So making sure that your packs works with this, and determining just these kinds of mechanistic issues that might be limiting factors. So I think it's completely appropriate. Yeah.
Clemente, you first or me first?
I was going to ask our guests if you would, if you have any comments or anything you would like to say before we speak.
It was all wrong.
Don't feel obligated, but just
No, listen, that was a great talk. I'm Chris. I'm one of the chest radiologists, and I do spend most of the time evaluating chest radiology software for Yale. And we actually do run a variety of these things. Well, we've tested a lot of them, you know. So for example, as far as computation, it's pretty minimal, the load. You know, we run, for example, PE detection in every CT we do at Yale, and it's pretty much instant. You know, the computation isn't so much of an issue with cloud computing. I will say that, you know, with the nodule CAD, unfortunately, what's kind of buried in this graph is that it finds a lot of tiny nodules. So the computer picks up tons of 2 and 3 millimeter nodules that the radiologists mostly ignore. And the reality is that, well, I mean, I could find all those nodules. It doesn't help anything, or in my opinion, help anybody. And when you look at these, you know, false negative cases in, you know, NLST or screening programs, you know, a lot of these were 2, 3 millimeter nodules. On one study, it was called, you know, LungRads 2 or LungRads 1. And the reality is it turned out to be something later, but it doesn't necessarily mean that the radiologist missed it as much as we, you know, just generally are trained to not focus on nodules that are not clinically significant. So that's always something to keep in mind with these. I will say that we had we used Siemens nodule CAD, for example. We ran a trial, did it on about 10% of our chest CTs for the last couple months. It really added a ton of time. It found a lot of false positives. You know, we didn't like it, so we didn't use it. You made a great case for the River Rain software, which I've been trying to convince the hospital to buy. You know, a bunch of our competing practices use it. It does save radiologists time by subtracting vessels, you know, decreases the cognitive load of reading the studies, but there's very little evidence that it really improves detection of nodules that are clinically significant as opposed to tiny nodules that, you know, are there. So
Agree with everything you said.
Yeah, I'm Anna Bader, Chris's colleague. Chris does all of our, or a lot of our IT thinking and sort of these, you know, fancier things that we do now. And excellent presentation. Thank you so much, especially going back to, you know, a lot of the important foundational work. So I'm one of the radiologists that tried a lot of these things, a lot of these programs, and they really are not helpful. That's the truth. I mean, there's nothing more than we'd like than some help with detecting nodules. We're not, as human beings, like detecting tiny things on 1,200 slices is not really our forte to begin with.
Innumerable.
Innumerable, exactly. Well, when we say innumerable, we really mean nothing. Anyway, so we really would love some help with this. It's just the reality is that it's a lot of nodules that are not, that we cannot prove are necessarily clinically important. And even the way that we report things are, you know, is trying to sort of make a clinical impression that will help the patient and help you guys take care of the patients. In terms of CAD, the radiologists with CAD helping, we actually have another algorithm, the ADOC, that runs nodules that we, as the chest section, did not want to use in our section, but the ED section actually uses it after the case is read. So as you said, radiologist and then CAD afterwards. And if there's a nodule that's above a certain size, I think they use 6 millimeters or maybe 6 millimeters, and they didn't mention it in the report, then they get an email to look at the case again at a later time, which has led many to want to detect nodules so they don't get an email afterwards. Oh, we did?
They canceled that.
Okay.
We actually tried a lot.
So it's not for lack of wanting this kind of help. Pretty much.
It finds a lot of nodules that aren't important. And the other issue is the commercial side of it. So we were testing this for a company, and they decided, you know, we tested it. We published some good results at Yale from their ED section, but it was decided this was not a commercially viable product, you know, so it was designed in a way that didn't stress the radiologist out, as it happens, because it would tell you, you know, 3 days later that to look at it again. But it just, you know, it didn't really find anything sensitive. We weren't necessarily missing things that were, 2 centimeter spiculated lesions. We were missing 2 millimeter nodules. So. Also, to the point of CAD, in radiology residency, you always learn to look at the images first and then use the CAD. This has been used for 20 years in mammography. And so we all learn how to do it. And that's technically the way you're supposed to do it.
Okay. Thank you, Finbar, for an excellent presentation. I just had a kind of a question. You may not know this, but I'm worried about, with Sybil and its available technologies and definitely its ability to predict sort of that cancer in the future. But what is the cost of these programs and how does it relate to the inequity of healthcare deployment and screening in the future for lung cancer?
There is no cost yet since it's not out there. It's not being used widely. I think, this is going to be bias in the implementation of these tools is going to be an ongoing issue, not just with lung cancer and lung nodules, but all of AI. Really worried that if AI learns from our own biases, then it will develop a biased view of the world. And so within lung cancer, if we're training it on 92% white individuals, how is it going to learn from other ethnicities, races, other income populations, et cetera? Currently the uptake of lung cancer screening is, less than 15%, in the 10% range, nationally. And are the individuals who are arguably at higher risk of developing lung cancer, ethnic minorities, those who are of lower socioeconomic status, not being made, not having the ability to access these screening tools. And so if we come up with bigger, fancier tools to apply to our CT scans, but we can't actually bring the people to the CT scanner and get them to follow up and get them what they need, what's the point? I think that is a big question where it's the same question with the liquid biopsy that we had a couple of weeks ago. Really fancy tool, is it going to get to the people that need it? That's going to be an implementation science question. Yeah. Thank you.